Thank you so much. Thanks to the OHTN so much for having me. This has been a really wonderful conference, and I've met so many amazing people. Thank you all for allowing me to speak today about my work with transgender people in the San Francisco Bay Area. I'm going to frame my talk in terms of visibility and vulnerability and how these might intersect for transgender people and impact the way that they access and experience HIV prevention and treatment. So just to get us all on the same page, I want to be clear about the terminology that I'm going to be using. When I talk about transgender women, I'm talking about people who have a female or feminine gender identity or expression, but were assigned the male sex at birth. And so sometimes they're referred to as male to female or M to F. Transgender men are people who have a male or masculine gender identity or presentation, but were assigned female at birth. So you might hear them referred to sometimes as female to male or F to M. In the Bay Area, we tend to not use acronyms to refer to people, but you'll see that language to refer to transgender people and the language that transgender people use to refer to themselves is very fluid. It differs by region, by ethnicity, by age, by country. So trans people also report a myriad of gender identities that fall outside of this binary, but for the purposes of this talk, I'm going to be talking about transgender women and transgender men. I'll start with trans men because I'm not going to focus too much on trans men. I've done some work with them in San Francisco, but overall we have very little data about trans men and their vulnerability to HIV, what their HIV prevention needs might be, but there is a subgroup of trans men who have sex with men who may be at risk for HIV based on sexual risk behavior with men, but the few studies that have been done have been showing fairly low prevalence rates, at least as compared to transgender women, and the studies usually show about 1% to 3% HIV prevalence among trans men. Trans women have gotten some increased media attention lately. The title of my talk was inspired by Orange is the New Black and the African-American trans woman actress who's featured on this show. And so there's been a new wave of attention to trans issues and to activists and to trans kids in the media. And so it's interesting to think about how this increased visibility might impact the trajectory of HIV prevention and treatment for transgender women in particular who have very high rates of HIV, and I'll talk about that. There's a long history of invisibility of transgender women and men in health research. And if transgender people are considered, they're often subsumed under other groups, such as LGBT or MSM. Typically in HIV surveillance data, transgender women have been categorized in the behavioral risk category MSM. Sometimes they'll be acknowledged as MSM-TG. But there are a lot of problems with that because what happens is the data that's specific to transgender people either isn't there, but the acronym implies that it is, or the data is invisible and we don't actually know how transgender people are affected by what's being studied. So I just want to give a brief recent example of the IPREX study that we're all familiar with. It was an RCT of PrEP and the results were published in 2010. And the guidelines were rolled out for demonstration sites last year. And so in the New England Journal of Medicine, as we all know, they had about 2,500 transgender HIV-negative men or transgender women, so transgender women were included in the sample, and the conclusions were, of course, that PrEP worked for the people in the study. There were about 366 trans women in the study, which was about 15% of the sample. Then the WHO guidelines got rolled out for the demonstration sites. They cited the high quality evidence that PrEP works for all the populations that were studied in the reviews that they did. But if you look closely at some of the data that's been released since then, they've actually done some sub-analyses on the transgender women who were in the IPREX study and found that it was not protective for transgender women. And this, not very many people have seen this data. It was an abstract that was presented at the IAS conference in 2011. And essentially, the investigators aren't sure why, but attribute it likely to adherence issues. And the principal investigator, Bob Grant, said there were insufficient numbers in the IPREX study to know whether PrEP works for trans women. Unfortunately, though, even though in other studies where they found that PrEP didn't work for certain populations, there's been an urgent call for further studies and really trying to find HIV prevention tools that work for the populations that they're intended to serve. But we haven't seen that level of attention given to trans people yet. This is from the Voice study where they're really calling attention to the fact that maybe PrEP isn't meeting the needs of non-trans women and that maybe we need to be looking at other HIV prevention tools. But we haven't seen that kind of urgent call for trans women yet, where there's sort of this working assumption that it works for trans women because they were included under the MSM category. So will the recent increases in visibility of trans people impact how we serve them in our HIV prevention and treatment programs? Well, some of the recent positive impacts of increased visibility include some new research that we have that really strongly documents the disparities experienced by trans people and the resiliencies. This new research has led to increased funding for trans-focused research. We have some new data collection recommendations that will accurately capture trans people in surveillance data and census data, electronic medical records, and program data. And then we have some funding for trans-specific intervention development work. And I've been doing some of that in the Bay Area. We also have seen some recent court cases in the media that have called attention to the rights of trans prisoners to retain their access to hormones and possibly even trans-related surgeries. So some of the disparities that have been documented recently, there was a publication this year in Lancet that looked at it was a meta-analysis of worldwide studies that had been done regionally around the world, looking at HIV rates among transgender women, and found that trans women had 49 times higher odds of HIV infection. In our area, in the San Francisco Bay Area, we see increased rates of mortality where trans women account for 2% of the population that are living with HIV, but 7% of the AIDS-related deaths. The community viral load is really high in the Bay Area among transgender women. And of course, like in other populations, African-American transgender women are really disproportionately affected. And then many psychosocial disparities have been documented, including major depression, suicidality, trauma, anxiety, substance use, and Greta Bauer's work has documented that here in Ontario. Some of the HIV treatment-related disparities that we've been looking at, there was a project called the Healthy Living Project that some of you might be familiar with, and it was 4 cities looking at access to antiretroviral therapy. And we found that transgender women living with HIV were less likely to be taking antiretroviral therapy than other groups. And those who were taking antiretroviral therapy reported lower adherence, lower self-efficacy to adhere to a daily medication regimen like ART. And whether they were on ART or not, they reported fewer positive interactions with their healthcare providers than the non-transgender people in the study. So in preparing to do some intervention development work for HIV-positive transgender women, we wanted to collect some qualitative data looking at barriers and facilitators to getting them engaged in HIV treatment, getting them on ART, and what is affecting their adherence to medications if they are taking ART. So we did 20 qualitative interviews and 5 focus groups. And the barriers that we found were that transgender women tended to report avoiding healthcare altogether. They were afraid of experiencing stigma from their providers, and that was based on past negative experiences. So, they had healthcare experiences that were traumatic and didn't want to, HIV was another condition that was going to force them to go to the doctor, and they didn't want to do that. Hormone therapy is also a high priority among many transgender women, and sometimes that can compete with other healthcare priorities like antiretroviral therapy. And they also expressed concerns about adverse interactions between their hormone therapy and antiretroviral therapy, such as the concern that ART might slow down their transition, or that hormones might have a negative impact on antiretroviral therapy, so they felt hesitant to begin ART without any good information. Some of the facilitators to transgender women reporting good treatment adherence were receiving culturally competent trans-sensitive health care. So if they had positive interactions with their provider, or they had a provider they could go to that was highly recommended by other transgender women where they felt safe, sometimes having a trans-specific portal to a clinic was a really strong facilitator. Getting social support from other HIV-positive trans women was a powerful facilitator as well. And the integration of hormone therapy into their primary HIV care, where they were seeing one provider for both their hormone therapy and their HIV care, where that provider was monitoring their hormone levels, monitoring their CD4 counts, their viral load, and really treating them as a whole person. And they weren't having to go from clinic to clinic trying to get their healthcare needs met. I wanted to briefly just go over the trans-inclusive data recommendations that have come out of some of the recent visibility of trans people, just in case people were interested in how to more accurately capture trans folks in your clinics, programs, surveillance data. And what's been recommended is this two-step method. The first question is, what is your current gender identity? And the second question is, what was your assigned sex at birth? And this works with transgender people and non-transgender people. Non-transgender people also know what their current gender identity is and what sex they were assigned at birth. And any difference between the two flags a person with a trans spectrum identity. So the current gender identity could be any identity along the trans spectrum and doesn't limit that person to identifying themselves as either a trans woman or a trans man. They can say they're genderqueer, other trans identities, but if it doesn't match the second question, then you'll know that you have a trans person accessing your program. In doing some of that intervention development work, I wanted to come up with a conceptual framework that was trans-specific. There was nothing out there that really spoke to some of the very unique needs and motivators that trans people in the work that I was doing was expressing. And there had been this concept of gender affirmation that was alluded to in the last decade or so in some of the work that's been done. And I was really interested in looking more closely at that, as it was something that was coming up a lot in my work. And as I did some of my formative research, I noticed that this concept of gender affirmation really had two dimensions. One of the dimensions is the level of access to gender affirmation that the transgender person has. Do they have support from their friends, family, for their gender identity and expression? Is their gender identity and expression being mirrored back to them in an accurate way that feels affirming of who they are? The other aspect of gender affirmation is the need for gender affirmation, where transgender people really report wide variety in how important things like being perceived as a non-trans person is. For some people, it's very important. It's still very dangerous in our society to live as a visible trans person. Even though it's a positive thing that trans community has gotten more attention and visibility, being visible as a trans person still makes a person highly vulnerable. But some people have more of a desire to what we call pass or live stealth, be perceived as a non-trans person. For other people, it was not as important. Part of how I used this conceptual framework to hypothesize how this was related to risk was I was thinking about how the need for gender affirmation might not match the level of access that person has. So if a person has a very high need for gender affirmation but low access, maybe they don't have access to transition-related care that they need, to hormones or the surgeries that they want. Maybe they don't have good levels of social support. And that unmet need is what predicts risk. So this was the theoretical model. I won't go into too much detail for the sake of time, but basically objectification theory, identity threat model of stigma, and Rafael Diaz's oppression and sex in high-risk contexts all informed how I thought about how this unmet need for gender affirmation might result in risk behavior, which could be risky sex, limited employment and educational opportunities often push transgender women into sex work, which can be risky. Substance use to cope and diminished self-care were all part of the risk behavior that I was thinking about. So in a cross-sectional study, I'm still analyzing the data now, but some of the preliminary data provides some support for this idea, where unmet need for gender affirmation among HIV-negative participants in my study was correlated with unprotected receptive anal sex with HIV-positive partners. And among HIV-positive participants, it was correlated with having a detectable viral load. So both of those outcomes are related to increased risk of HIV transmission and acquisition. I'm going to talk about two of the interventions that I'm currently working on. The first one is Shiro's, and it's a small group, peer-led, 5-session intervention that's aimed at reducing sexual risk and increasing self-care. It's a mixed status group, so we have both HIV positive and HIV negative women and unknown status women in the same group, kind of educating each other, learning from each other, encouraging each other, and that's really based on the idea that transgender women, the experience of being transgender kind of supersedes their HIV status in terms of what they have in common with each other and the support that they're able to give. And we found that really worked in our pilot cohorts. We've done 3 cohorts with 27 transgender women. We have some preliminary support for its efficacy, and we're starting a pilot RCT in January. I know this isn't readable, but I just wanted to give you an idea of what the sessions entail. So the first session is really about gender pride, taking pride in one's transgender identity or trans history. And the second one is looking good and feeling good, really starting to talk about gender affirmation. The third one's all about sex. And the fourth one is about empowerment and how to empower oneself in the face of transphobia. And the fifth one is about surviving and thriving. So really talking a lot about self-care and substance use, the importance of knowing one's status and getting treated if you're positive. The second intervention we've been working on is called Healthy Divas. It's specifically for HIV-positive transgender women and looking at getting them engaged in care and adhering to the treatment. It's also informed by the model of gender affirmation and the model of healthcare empowerment, which was developed by my mentor, Mallory Johnson. And they have sessions with a peer educator and a group workshop where they get an opportunity to talk to a trans healthcare expert and an HIV care provider. I briefly wanted to mention a national project that we're just getting started. It's funded by HRSA in the US, obviously, and they have 9 demonstration sites funded to enhance engagement and retention in HIV care, where these sites are developing their own interventions and testing them to see how they can improve their retention of HIV-positive transgender women of color in their programs. And we at the Center for AIDS Prevention Studies are the evaluation and technical assistance center for that project. So we think there's going to be really, really great data that come out of that. Very exciting. Just some quick recommendations. If you're looking for ways to make your programs or clinics more trans-inclusive, consider implementing the 2-step data collection method to more accurately collect data about your trans clients and patients. Using targeted peer outreach is invaluable, and peers are really the experts in knowing how and where to reach their community. Definitely you need to include gender-affirming content to attract transgender clients and patients. Just saying that your program's available to transgender people isn't usually enough to attract them. Integrating hormone therapy into primary HIV care is not a difficult thing to do. We have a physician on staff who's our lead expert in training physicians to do this, and she likes to say that it's not hard to do. It's actually really easy. If you're an HIV care provider, it's something that can be really extremely valuable to your trans patients, and we'll definitely keep them coming back and support their adherence to their medication regimen. So just a brief nod to my funders, my colleagues, my mentors. I work with 2 different community advisory boards at the Center for AIDS Prevention Studies and the Center of Excellence for Transgender Health, the participants, and that's one of our community advisory boards. So thank you so much.